This lecture continues Chapter 41, Infectious Diseases. It starts with the viral infection mumps. For manifestations, prodromal manifestations include fever, myalgia, headache, and malaise. The classic clinical sign of parotid glandular swelling often follows these, although a substantial number of individuals have no such swelling. When parotid swelling occurs, it can be accompanied by fever. And here's some visuals of that parotid glandular swelling. Mumps generally affects the salivary glands but can involve multiple organs. The most common complication is aseptic meningitis, with the virus identified in the CSF. Signs of CNS involvement include nuchal rigidity, lethargy, and vomiting. The potential complication of most concern to parents is orchitis, or inflammation of the testes. Orchitis is a complication frequently seen in adolescent boys and almost never before puberty. However, sterility is uncommon. Uncomplicated mumps may require only symptomatic care and encouragement of adequate hydration. Avoidance of acidic foods such as orange juice is helpful. Droplet precautions would be used. Orchitis requires bed rest, intermittent applications of ice packs, pain management, emotional support, and diversional activities. Typically, children with mumps are not hospitalized unless they have complications. Meticulous hand hygiene techniques should be taught to the child, the family, and close contacts to prevent transmission. Hospitalized children are placed in isolation according to facilities' policies with droplet precautions. Again, primary prevention of mumps will occur with the MMR vaccination, that is a live vaccination. MMR is given at age 1, and then a booster around ages 4 to 6 years of age. Next, we're going to talk about pertussis, also known as whooping cough. It is a bacterial infection. There are 3 stages of pertussis. Catarrhal is listed in box, all the 3 stages are listed in box 41.1 on 918. Catarrhal is the first signs and symptoms that you'll see, symptoms of upper respiratory tract infection with rhinorrhea, lacrimation, mild cough, and low-grade fever. Paroxysmal is the second stage, increased severity of cough, repetitive series of coughs during a single expiration, followed by a massive inspiration with a whoop. Older children may not manifest this. Cyanosis, protrusion of the tongue, salivation, distension of neck veins. Coughing spells may be triggered by yawning, sneezing, eating, or drinking. Coughing may induce vomiting. In the convalescent phase, episodes of coughing, whooping, and vomiting that decrease in frequency and severity. Cough may persist for several months. Diagnosis is through positive nasopharyngeal culture. The most frequently seen complication of pertussis is pneumonia. Other respiratory complications occur to varying degrees, ranging from atelectasis to interstitial or subcutaneous emphysema to pneumothorax. Hypoxemia can lead to CNS involvement. Malnutrition and dehydration can result from excessive vomiting and can be quite dangerous, especially in infants. Other complications include otitis media, ulcers of the frenulum of the tongue, epistaxis, hernia, and rectal prolapse. Infants younger than 6 months of age are at greatest risk for complications. Under therapeutic management, primary prevention of pertussis can be accomplished through the administration of 5 doses of the pertussis vaccine in combination with tetanus and diphtheria, DTaP. And DTaP, the P stands for pertussis. Because of waning immunity in the adolescent population, the AAP in 2006 recommended a booster called a Tdap for children ages 11 to 12. Children receive their first DTaP vaccination at 2 months of age, and again they receive a booster between the ages of 11 to 12 years of age. Also, adults, sometimes elderly adults who are becoming grandparents for the first time, will get a booster shot also to help protect themselves and their grandchildren. Erythromycin, azithromycin, or clarithromycin, if given during the catarrhal stage, will eliminate the organism from the nasopharynx within 5 days, thereby reducing communicability. Erythromycin, azithromycin, or clarithromycin is also given to all close contacts, which include most children older than 13 years, because the immunity conferred by the childhood immunization declines by early adolescence. Hospitalization and supportive care for the infant may be necessary, especially those 6 months and younger, since they are at increased risk of mortality, to monitor airway patency. Older children are usually cared for at home. Respiratory status is monitored using a cardiopulmonary monitor or pulse ox. Droplet precautions are observed. It is vital for families and caregivers of young infants to be immunized against pertussis. Of note, recent studies show that siblings are now the most common mode of transmission. Documentation also includes the parent's description of any respiratory event before admission and indicators such as coughing, secretions, cyanotic episodes, and the child's level of activity. Assessment of the child's respiratory fluid nutrition output and neurologic status should be done. The child's respiratory status needs monitoring, again with cardiopulmonary monitoring or pulse ox. Supplemental oxygen therapy may be needed. Because of the child's coughing, paroxysms can be triggered by noises or frightening experiences. A quiet environment and a calm, reassuring approach should be used when caring for the child and supporting the caregivers. Caregivers and children will need additional support and reassurance that assistance is near and ready if needed during the child's coughing spell, because the episodes can be extremely frightening. The infant's nutritional status needs to be closely monitored. Small, frequent feedings may benefit the infant. And if you have time, I would just Google a whooping cough and try to listen to some auditory recordings of those so you know that what it sounds like. The next bacterial infection we're going to talk about, scarlet fever. It's caused by group A beta hemolytic streptococci. Abrupt fever, vomiting, headache, abdominal pain, pharyngitis, and chills characterize the onset of scarlet fever. Within 24 hours, a fine red papular rash appears in the axilla, groin, and neck, which feels like sandpaper to the touch. The rash then spreads peripherally to cover the entire body. The rash will blanch on pressure, except in areas of deep creases. Desquamation is peeling of the skin and may begin on the face at the end of the first week, and flaking proceeds down the trunk. This process may continue for up to 6 weeks. The tongue is initially coated with a white, furry covering with red projecting papillae, so-called white strawberry tongue. By the 4th day, the papillae slough off, leaving a red swollen tongue, so-called strawberry tongue. The tonsils are edematous and may be covered with a gray-white exudate, which can spread to the pharynx. Petechial hemorrhages cover the soft palate. Complications generally result from the extension of the streptococcal infection. They include sinusitis, otitis media, mastoiditis, peritonsillar abscess, bronchopneumonia, meningitis, osteomyelitis, rheumatic fever, and glomerulonephritis. Therapeutic management: a rapid strep screening in the office, usually with lab confirmation. If the RAP screening is negative, is recommended for children with sore throat because of the similarity of symptoms between viral and group A beta hemolytic streptococcal sore throats. The preferred treatment for any strep infection is penicillin. Children allergic to penicillin can be given erythromycin, a cephalosporin. Droplet precaution should also be observed until the child has been on an antibiotic for 24 hours. Complications for an untreated group A beta hemolytic streptococci infection include acute rheumatic fever and acute post-streptococcal glomerulonephritis. Under nursing considerations, the nurse should assess the child's throat, tongue, rash, nutritional and fluid intake, vital signs, and level of general wellness. Generally, children with scarlet fever are cared for at home. Comfort measures including encouraging fluids, especially cool, non-acidic liquids, and administering antipyretics for fever control. Analgesics may be given for discomfort, and antipyretic comfort measures may be necessary. Parents should understand the typical course of disease and any treatment measures, including the importance of completing the full course of antibiotics prescribed. Bed rest and quiet activities may be beneficial during the acute stage. And then you have a box, how to care for your child with scarlet fever. Again, take the entire course of antibiotics. The child should Cool drinks and liquid refreshments may help maintain hydration. Acetaminophen, ibuprofen, throat lozenges, antiseptics, throat spray, and cool mist may be used to relieve discomfort. Encourage quiet activities will help prevent fatigue. And providing oral care, acidic preparation should be avoided. Saline rinses can provide comfort and promote hygiene. A soft, bland diet should be offered. And caregivers should be advised to call the primary healthcare provider if the child develops drooling or great difficulty swallowing or acts very sick. After 48 hours of antibiotic therapy, the child should not have a fever. The child is no longer contagious after 24 hours of antibiotic therapy. The rash is not contagious. Polio is caused by a virus. It's spread fecal to oral route or oral to oral route. Because of a successful vaccination program, the U.S. has been polio-free since 1979. Children receive 4 doses of the polio vaccine or the IPV vaccine. The first dose is at 2 months of age, and the final booster dose is between 4 to 6 years of age. You can find polio in your textbook on page 922. It's just a small little blip in table 41.1. Again, table 41.1 on page 922. Manifestations of polio include fever, malaise, anorexia, nausea, headache, sore throat, generalized abdominal pain, which begins as mild, then grow to more intense. So the more concerning manifestations of polio include flaccid paralysis, especially of the lower extremities. Cervical involvement can involve or affect the respiratory and vasomotor centers, resulting in potential damage to the respiratory centers and inability to breathe. There is no specific treatment for polio. Respiratory paralysis is treated with mechanical ventilations. Prior to the vaccinations, patients in the U.S. with polio were placed in iron lungs, which helped with their respirations. Physical therapy helps maintain muscle integrity and prevents contractures. Again, prevention of polio occurs through routine immunization. And you may care for patients, older adults who had polio as a child or prior to the vaccines being developed. And those patients sometimes have lingering side effects, such as paralysis of the lower extremities or difficulty walking, things of that sort. And then finally, we're going to talk about diphtheria. It's also contained on table 41.1 on page 922. It's caused by a bacterial infection, transmitted through contact with carrier or disease or droplets. Nasal manifestations initially resemble the common cold, then gradually begin to include discharge of foul-smelling mucopurulent material. Low-grade fever is common. The hallmark sign is a thin gray membrane on the tonsils and pharynx, causing bull neck or neck edema. A nursing concern is to watch for respiratory compromise due to a narrowing of the upper airway. Complications include upper airway obstruction, myocarditis, and peripheral neuropathies. Prevention through routine immunization and boosters at the recommended intervals helps prevent diphtheria infections. Diphtheria vaccination is combined with the vaccination for pertussis, so it's part of the DTaP vaccinations. And then again, the first dose would be given to the child at 2 months of age, and they would receive a booster dose, their final booster dose, between 4 to 6 years of age.